Today's speaker is Professor Alta Charo. He's speaking on the allocation of a SARS CoV-2 vaccine, but we also have three other speakers lined up for this academic year that I wanted to let you know. The next on January 28th will be Dr. Josh Sharfstein, who's Vice Dean and Professor for Public Health Practice and Community Engagement at the Johns Hopkins Bloomberg School of and former Secretary of the Maryland Department of Health and Mental Hygiene, as well as the former Principal Deputy Commissioner at FDA. And he will be discussing the politics of public health regulation. Our third speaker will be on February 23rd, and she is Professor Rakaya Yerby. She is the Executive Director of the Institute for Health, Justice, and Equity, and on the faculty at the University of St. Louis Law School. And she'll be speaking on eradicating systemic racism in the government's pandemic response. And then last but not least, on March 31st, we will be hearing from Jessica Roberts, who's a professor of law and chair in law, a professor of medicine, as well as director of their health law and policy at the University of Houston Law Center. We haven't finalized the topic yet for her talk, but it will likely be on contact tracing or privacy in the terms of service of health apps. So we hope you will zoom into those as well. Before we introduce our speaker for today, I just want to let you all know that this session is being recorded. In introducing our speaker will be Professor Leslie Meltzer-Henry, a member of our faculty who teaches bioethics, public health law, and constitutional law, among other things. And she'll also be moderating the Q&A. So I'll now turn over the Zoom camera to Professor Henry.
Thanks so much, Diane. And let me extend a warm welcome to all of you. It's nice to virtually see so many of you here tonight to help us welcome and learn from Professor Alta Charo. Before I say more about her, I want to also extend my thanks and appreciation to Karen Rothenberg and Jeffrey Seltzer as well for helping to sponsor this really terrific series. So as many of you know, in response to COVID-19, the coronavirus pandemic, and the societal disruption that it's brought, national governments and the international community have invested billions of dollars and immense amounts of human resources to develop a safe and effective vaccine. They've also tried to do that in an absolutely unprecedented time frame. Vaccination against this virus, SARS CoV-2, offers us the possibility of significantly reducing morbidity and mortality, as well as perhaps transmission when it's deployed alongside other public health strategies and therapies. But despite all of our best efforts to develop safe and effective vaccines against COVID-19 and to ramp up our production, it is, according to the National Academies of Science, Engineering, and Medicine, inevitable, as many of you might suspect, that our initial vaccine supply will reach everyone. Therefore, policymakers have had to turn their attention to developing plans that will ensure the equitable allocation of this vaccine until there is a sufficient global supply. This, of course, raises very difficult ethical questions and questions that implicate social justice as well as public health. So in response to a request from the National Institutes of Health and the Centers for Disease Control, the National Academies formed a committee that has produced a consensus study to assist policymakers and global health communities in planning for the equitable allocation of these vaccines. And I'm delighted to say that this evening's speaker, Professor Alta Charo, is a member of that committee, the Committee on the Equitable Allocation of Vaccine for the Novel Coronavirus. Can't think of anyone more appropriate to enter and begin this exciting seminar series. For those of you who don't know Professor Alta Charo, her reputation often precedes her. She is a professor of law and bioethics at the University of Wisconsin, as well as an internationally renowned leader in the fields of bioethics and biotechnology, as well as reproductive healthcare. In 2016, she sat as a member of the National Academies Human Gene Editing Initiative, and she's also co-chaired multidisciplinary committees in the same topic area. Between 2009 and 2011, Professor Charo served on President Obama's transition team as an advisor to the Department of Health and Human Services, and then later as a senior policy advisor to the Food and Drug Administration. Somehow, in addition to serving on all of these advisory boards relating to things such as stem cell research, ethics and clinical issues in research, she's authored or contributed to over 100 articles, book chapters, and government reports on law and policy, like the one we're looking forward to hearing her discuss tonight. So without further ado, I'm going to turn things over to Professor Charo to talk about COVID-19 vaccine allocation is the title of her talk. Welcome, and thank you so much for being with us tonight.
Well, thank you very much. That was really quite a lovely and rather over-the-top introduction. I have to say first that it's an incredible pleasure and honor to give this talk because Karen Rothenberg is a very special person for me. She was one of my very first mentors and helped me get through those crucial years when you can't quite imagine how you could accomplish as much as the people you're looking up toward. And so, Karen, this is for you. Thank you. I'm going to take a moment here just to do the whole share screen thing and put up some slides for you. And let's see, slideshow from first slide. And I'm hoping that that can be seen okay at this point. Great. Yes, Professor Henry is quite correct. I was on a National Academies committee that was asked by the NIH and the Centers for Disease Control and Prevention to provide advice, but just so you understand the positioning of this, to provide advice to the Centers for Disease Control's own advisory committee called the ACIP, which then would advise the CDC itself, which would then advise state authorities. So we are several degrees of separation away from actually having any power. So these are all advisory only. I want to start first by just cluing you in on one of the more interesting events in the course of trying to figure out how to allocate what is going to be, at least initially, a scarce supply of vaccine. There is a fraternal order of real Santas, and they lobbied to get early access to a vaccine because, as they said quite correctly, they are going to have large numbers of people coming to them, so high personal contact, lots of opportunities for exposure to the infection. Most of them are older and overweight and therefore are in high risk categories, and they could provide a kind of role model to help calm the public, many of whom are skeptical about the safety of the vaccine. So it wasn't as crazy as it sounds, and it was actually pitched to the Department of Health and Human Services as part of a $250 million effort to try and promote vaccine use. In the end, it was withdrawn for a variety of reasons, one of which is certainly that we probably will not have a vaccine to distribute that early anyway. Where are we now in this particular pandemic is probably worth noting before we really get into it. As you can see from this, we are quickly approaching 10 million cases in the United States of infection and approaching 250,000 deaths. The map here is one that should alarm all of us. It especially alarms me here in Wisconsin because we are now in a terrific hotspot, and you can see how the daily totals have been increasing. Deaths will start increasing at the same rate as infections pretty soon. They usually will lag behind infection by about 2 or 3 weeks. Another aspect of the epidemic I need to emphasize before we talk about vaccines is how very unevenly it has been affecting people. And this is not news to you guys. We know that there is a tremendously disproportionate effect on people who are members of minority groups, particularly if you're African American, your chance of getting infected overall is about 3 times higher, chance of dying about twice as high. One of the things that really startled me when I was part of this committee and listening to testimony was to learn that the rates were 500% higher in some indigenous communities in Alaska and Hawaii. So we really are facing a crisis in terms of inequities that we've always known about, but are now really being thrown into high relief. Now, that's not because of some underlying biological difference between, let's say, the non-minority population and these groups. Instead, it's that socioeconomically, we see that these groups are disproportionately represented in high-risk jobs that involve lots of personal contact, as opposed to people like me who are lucky enough to be able to interact with you safely from my own home. They also frequently have had no or inadequate health insurance in the past, and so did not get nearly the same amount of preventive care, and have therefore had all kinds of illnesses wind up becoming more severe before they get any treatment. And finally, they tend to live in situations that are more crowded, very difficult to achieve social distancing. So we know that this creates a real problem for minorities, but that's not the only group that has disproportionate representation among those getting sick or dying. It's also people who are older, people who have specific comorbid conditions, things like diabetes, and immune system compromising illnesses, as well as people that live in congregate housing. That would be nursing homes, but also prisons, also halfway houses. So we've got lots of groups that are particularly vulnerable, and it's very important to keep that in mind when creating an allocation system that's designed to treat people fairly. I know that most of you know this, so I'm going to very briefly just remind you, or to introduce those who don't know it, remind you of how vaccines are developed, approved, and manufactured. Like other drugs, after various levels of laboratory research, the vaccine trials go through a series of phases. In the first phase, a very small number of people are given very tiny amounts of the vaccine that's going to be tested, just to see how the body metabolizes it, and just to check whether there will be any acute toxic reactions to it. After that, a phase 2 study often is several hundred, maybe 1,000 people. And what you're doing then is you're beginning to look first at how safe it is across various dosages, and also looking for the first signs it might be effective. And to do that, you have to divide the population in half that you're studying. You'll have half the people who get your test vaccine and half the people that don't. And then they all go back their lives, all practicing public health safe practice measures like hand washing and masking. And you need to wait until enough people in the unvaccinated group have actually been infected to be able to tell that there's a significant difference between those people and the people who are in the vaccinated group. So you can see that it's vaccination that makes the difference. And after phase 2, you really want to test this out on much, much larger numbers to make sure that this was not a statistical fluke. And so we're talking about literally tens of thousands of people in phase 3. Some of the trials we're looking at now are up to 60 and 70,000 people for enrollment. The number is also important because it allows you to break those groups down and look specifically at how dangerous and how effective a vaccine is for people who are older, people who are younger, people who have various kinds of risk factors. Only after this process is a vaccine ordinarily approved for use in the United States by the FDA. When there is a public health emergency declared by the Secretary of Health and Human Services, it is possible to also approve this vaccine on a so-called emergency use basis that allows it to go out before some of the phase 3 trials have been completed, and when there's a good reason to believe that it will ultimately prove to be safe enough considering its risks. But with the emergency use authorization, you also don't get quite the same robustness of information as you would like. If we take a look at where we are on vaccines today, this is from today's New York Times. Well, I guess it's from October 29, so we're 3 days out. Virus vaccine tracker. You'll see that we've got quite a large number that are in phase 1 and phase 2, you'll see that these numbers drop off, not just because some have started more recently, but because some just don't. Some just don't look like they're safe enough or don't look like they'll work well enough to proceed through the phases. This group of 6 of limited vaccines, these are all in Russia and China. And they did not go through the same phase 2, phase 3 trials we are using. They would not be approved by American standards. And so that's why the number 0 here represents the number of approved vaccines in the United States, although we do now have some that, as you can see, have gone into phase 3. When will we actually get one? Well, keep in mind, there are multiple vaccines being tested simultaneously, as Professor Henry had mentioned in the introduction. So the question is, when will the first of several begin to roll out? Tony Fauci from the National Institutes of Health has said that the findings that would allow the FDA to make a decision may be available by December. But that decision can take a while as well, because the data has to be reviewed very carefully before the FDA issues the emergency use authorization, if that's the route that they're going to go. And after that, there's time for scaling up. One of the benefits of Operation Warp Speed was that the government took out the economic risk associated with scaling your manufacturing up to the size you would need for ultimate distribution. So these companies that don't yet know if their vaccines will ever be approved have been investing tremendously in making large enough quantities that it could be distributed. And if it fails, the government covers their costs. That's a very new way to approach vaccines, and is something I think we really need to look at carefully as an experiment in a new way to promote the development of needed therapeutics by de-risking economic risk for the companies. But because there are multiple vaccines that are going to roll out, and they'll roll out at different times, and they're all going to have slightly different profiles in terms of safety and effectiveness. Some may have some side effects like, let's say nausea or fever, and another one might have a different side effect having to do with muscle aches. Some might have slightly higher rates of serious adverse events, but also be far more effective. And some might be better for older populations rather than younger. And so it's going to be very confusing at the beginning, because when the first vaccine comes out, it's not going to be clear to everybody whether it's the vaccine they ought to be taking, or whether they should, if possible, sit back and wait for one that's more carefully tailored to them. What's worse is, because the other vaccines will not have been finished yet in their trials, most of the people you would ask these questions of, your physician and your public health officials, won't have an answer. Now, how early can we actually get any of these out? As I mentioned, the emergency use authorization was predicted for a while to be the main mechanism. There's now some sign that we may actually sit back a little bit and not move quite that fast. Why? Because there's some concern that there's been so much political debate around the vaccine and so much suspicion that it's been caught up in election politics. Skepticism has been rising and confidence has been dropping. And if you then add on a special early release, it only feeds the skepticism at a time we really need confidence so that those who are offered the vaccine will in fact choose to take it. The other is that by having an early authorization, we lose the chance to actually have longer term follow-up and to see which vaccines really work best in which people. So there is now some discussion about perhaps waiting for formal approval. That will take even longer. And then for a limited number of people who are really in a particularly vulnerable position, perhaps having a narrower program for expanded access to an unapproved form of the vaccine. One of the reasons why there are so many uncertainties about what's going to be the best vaccine and in what order is something that really emerged only when AstraZeneca was forced to reveal more about the particular protocol it was using. This then presaged other companies also doing this. The thing that really surprised many observers was that the tests were not testing to see whether or not the vaccine necessarily prevents somebody from becoming infected. That would be important because if you're not infected, you can't transmit it to somebody else. Instead, a success in these trials is being measured by either not getting infected, or if you're infected, not getting very sick, symptom reduction. Now, that's perfectly valid. It's how we do flu vaccine for the seasonal flu. But here, if somebody is infected and doesn't get terribly sick, they are still capable of transmitting the virus. We don't know yet if they're more or less capable than if somebody is severely infected, but the point is that we don't know what the vaccine does to reduce transmission. This becomes really crucial because there are two reasons you want people to be vaccinated. One is to protect themselves. The other is to stop them from spreading a disease. And those two goals lead to different groups that you might prioritize when it comes down to allocating a scarce resource. And here we have a big question mark over one part of that goal, which is stopping transmission. So we don't know whether or not, for example, to prioritize for people who are in essential industries but have high frequency contact with people or are in necessarily high density workplaces. This would be the people like the meat packers who were getting infected at large numbers early on. Would vaccinating them protect some of them from getting infected? And we're looking only maybe at 50 or 60% effectiveness at getting of the vaccine at all, at protecting people. But would it have done anything to stop the wildfire transmission? We don't know. And when you come to things like nursing homes and prisons, the transmission factor becomes quite dominant in your thinking. So this is a very problematic area of uncertainty for us. There are also other uncertainties where it might be that a vaccine that comes out third or fourth or fifth in the rollout of these different company efforts, some of which are based on entirely different kinds of biological mechanisms, some of them might be better for the elderly. Some of them might be better for people who are already sick with something like diabetes. And so that also would affect the order of priorities in terms of which people go first and how we identify them. And then we can't really talk about allocation as if once you've offered a vaccine, it's going to be taken. So you know your allocation framework represents what's going to happen in the field. In fact, quite the contrary. There's been an enormous growth of refusal and hesitance about vaccines generally, based on tremendous misinformation, coupled with being a victim of our own success, where all kinds of diseases that some of us grew up with are now rare and hardly mentioned or noticed by the population because vaccines have been so successful. And so many people today don't routinely see their friends getting sick with measles or chickenpox, and it becomes a little less obvious why you should be vaccinated for what now looks like an imaginary disease. But for this particular vaccine, on top of that comes the effect of politicization, as I mentioned earlier. And then for minority communities, which I've already mentioned, tend to be also a convergence of factors having to do with lower socioeconomic status and higher risks. That community also has a history of having been abused in research trials and having been taken care of less well in medical contexts generally. And so suspicion runs high. The New York Times had a magazine story a little while ago in which there were people in minority communities saying they didn't want to go first even after a vaccine's approved because they didn't want to be guinea pigs for everybody else. So we have this irony in which the community that probably needs vaccination most desperately is also the community that has some of the highest level of skepticism. It's because of this problem of skepticism that we're beginning to see more pullback from the idea of getting the vaccine out early. This is the German health minister, Jens Spahn, and he was quoted just a couple of days ago, I guess it was 2 days ago, as saying that the most important thing for acceptance is that we wait for all the clinical trials to complete. That would suggest that you don't do things that would be the equivalent of an emergency authorization as we would do here based on phase 2 or incomplete phase 3 trials, but instead you wait for all the trials. It's a balancing act because if the vaccines really save lives, then every week or month that you haven't put it out there, that's some number of people who will get sick and some number of those people dying because you didn't put it out there. But if putting it out there early also means that you have vast numbers of people who never get vaccinated, that's a different group of people whose numbers of sick and dying will increase. And so there's a tremendous amount of modeling going on, trying to predict what the numbers are under each of these scenarios. In the United States, you can see that the confidence in the vaccine has been going down steadily over time. And so you can see from mid-August until about a month ago that you've got drops. And at this point now, we're looking at only about 4 in 10 people from the African-American community saying that, yes, they want to get the vaccine as soon as it's available. This is very worrisome because you really need to have a very high prevalence of vaccine coverage in order to slow the transmission if the vaccine even has that benefit of slowing transmission. So as I mentioned, these are the cluster factors for those minority groups that we're so worried about: higher density housing, less insurance coverage, higher rates of obesity, as well as diabetes and other comorbidities, service jobs where they can't protect themselves by working from home or maintaining distance. There's a higher density home life, and also multi-generational housing, so that somebody who's in their 20s and is somewhat less vulnerable to getting seriously sick with the virus and is out there working in one of these delivery jobs or as a orderly in a hospital, comes home to a multi-generational setting in which there are the elderly and the sick and the very young. So again, other reasons, yet more reasons why this is a problematic situation. It's against that backdrop that our committee came up with our best effort at a framework for equitable allocation. We wanted to have a goal that would then feed into criteria and phases. And the goal, you'll notice, is one that encompasses several things. We're talking about reducing severe illness and reducing deaths, as well as trying to bring society back into a functioning mode, which means that you have to be able to open it up somewhat. We tried to come up with foundational principles that would guide us in our decision-making when we were trying to achieve those goals. So for benefit, we very specifically looked not only at benefit to the individual person in terms of their physical health, but also looking at the benefit to society overall. And keep in mind, with all the people who are out of work or people who are no longer able to afford their homes or unable to continue their educations properly, these too have indirectly, but quite predictably, significant health consequences down the road. So by encompassing socioeconomic concerns and economic concerns, we are also trying to address public health in the long run. We also thought it was very important to have equal concern for people so that we didn't in any way preference some people over others because of some prediction about whether or not they would live a long time or only a short time, because those predictions are only predictions. But at the individual level, it's an absolute access or absolute non-access to a therapeutic, or in this case, to a vaccine. And we wanted to see if we could work toward mitigating some of those health inequities that we had identified. To do that, procedurally, we understood that we had to be fair. That is, whatever criteria we had to administer them in a uniform fashion. They had to be criteria that were publicly available so people could critique the criteria, and we had to base them on evidence instead of on intuition. So overall, we were trying to accomplish a lot of things, many of which were somewhat in tension with one another. I'm going to get back to the specifics about what we did, but I wanted to just turn for a moment to what happened then with the Standing Advisory Committee to the CDC, which looked at our recommendations as well as other sources of information, and are still working on their own scheme that they will then present to the CDC as their best advice. So this is a piece that came out just about 10 days ago based on their last thinking. And what you'll see is that, like what you're going to see from the National Academies, they are dividing the phasing of the vaccine into priority groups. And as you are also going to see, there's a lot of overlap in how people wind up coming around to these things. Phase 1A, healthcare personnel who really are at risk. So it's the people who are working in the ICUs, it's the orderlies, it's the janitors who are in the rooms of the patients who have been infected. And we need to do that first so that we can make sure that they continue coming to work to help the rest of us. Then in phase 1B, essential workers, and we should talk later if you like about how you define that, as well as people with high risk underlying medical conditions and the elderly. Now, there's a lot of overlap in these groups, but even so, they figured that's probably 200 million at a time when for phase 1, we may only have 15 million doses. So this really doesn't get us as far as we would like necessarily. I suspect that really all we're going to get to in the very first phase is going to be this group of healthcare personnel. Some of the comments, though, are very interesting, and they play up how it is that there are a lot of tensions here. For example, one version in which you vaccinate the high-risk adults or essential workers first, you prevent more infections. So you prevent more overall illness. But if you focus on the elderly, you'll actually prevent more deaths because the elderly die from the infection at much higher frequencies than younger people. So which is your goal? To stop illness or to stop deaths? Because even people who recover from the illness may have long-term consequences, and we're already seeing some evidence of that. So even that turns out to be two goals that are somewhat in tension with one another. And that's why they said if the goal is to avert deaths, then let's just vaccinate elderly people. We saw the same kind of data at a presentation at one of our public meetings at the National Academies. But despite that, pretty much everybody comes to conclude that you have to start with the healthcare workers because they are the wedge that gets us into everybody else and delivery of both therapeutics and vaccines. So the National Academies allocation went into somewhat more depth. It also starts, as you can see, with healthcare workers. And then as we get into the next round of vaccines, looking then at people with comorbidities that put them significantly higher risk, not just moderately, as well as now looking among the elderly at those who are in these congregate settings. The nursing homes are a high priority. In phase 2, we look at teachers, but notice that we don't get to children till phase 3 because teachers need to be protected for themselves as well as hopefully being protected from becoming vectors to other people, including children. And children, we've discovered, do get infected. Some of them do get sick, including with some very specific illnesses that you only see in children, but at much lower rates. So there was an effort to distinguish these two things. But now also in phase 2, we're beginning to pick up more congregate housing, homeless shelters, prisons, and making sure that we are trying to protect the people who are vulnerable situationally, as well as those that are vulnerable medically. Of course, we probably won't have enough in any of these, just like with the ACIP recommendations. And so within these, we recommended that if you don't have enough, let's say for people of all ages with comorbid conditions, that you actually then concentrate on the people who are probably going to have additional confounding factors. So we use the CDC Social Vulnerability Index, which takes into account a lot of things about income and education and smoking rates and a whole variety of other things, which would tend to suggest that people of all ages with comorbid conditions that live in the vulnerability index area are probably going to get sicker than the people over here in a different area. And so this becomes an overlay for every population group as long as there isn't enough to vaccinate everybody in that group. I'm practically at the end. I just want to summarize by saying that we recommended that the ACIP and therefore the CDC adopt this framework and then share it with the states. Each state now has its own committee looking at particularly local conditions. I serve on the one here in Wisconsin to develop principles here in Wisconsin, where essential workers, for example, may differ from place to place depending upon what it takes to function in an urban versus rural area, in a cold versus hot climate. There were also recommendations I'm not going into here about how to leverage the existing systems for delivery and for financing. But we've made sure to recommend that there ought to be no out-of-pocket costs for those who are being vaccinated, and that we also need to spend a lot of time trying to promote vaccines in an evidence-based way that gives people confidence. So it's about who is the messenger, what's the information, and how can we make sure the message is consistent and accurate from the beginning so that people aren't going to be skeptical and can be confident that it really is based not on politics, but on information. Last but absolutely not least, everything I've said was about the United States, but this is a global pandemic, not a national epidemic. And so we also very specifically pulled out equitable allocation of the COVID-19 vaccine globally. Um, we wanted to recommend that the US rethink its position about engaging with the global community in things like COVAX, which is a collaborative effort at manufacture and distribution of vaccines, in which countries that pledge to participate and contribute to it also are now guaranteed that if their own national efforts fail, that they can then take vaccine from this global, basically this global pocket or pocketbook of vaccine. So it's an insurance kind of provision as well, and it's being organized by the Global Alliance for Vaccination and Immunization, Gavi, which is a partnership of major foundations like Bill and Melinda Gates, as well as governments and a whole variety of industrial and NGO entities. Unfortunately, by my view personally, as well as in the statement from the committee, the US pulled out of the World Health Organization effort, which is part of this Gavi COVAX phenomenon. But we have the opportunity to rethink that decision. We also think it's important, no matter how desperate things are here, that we also keep back about a 10% supply of the vaccine in order to address global emergencies in the pandemic, keeping in mind that the SARS CoV-2 virus absolutely does not recognize national borders. So what helps people in other countries also helps us. So whether as a matter of morality or as a matter of national self-interest, we thought it's important that we actually consider ourselves part of the world and participate in an equitable allocation of vaccine to those countries that are already under pressure from their own public health systems and are already seeing the kind of toll that this can take. With that, thank you for your patience, and I'm happy to take any questions or listen to your comments.
Terrific. Thank you so much, Professor Charo. At this point, I'm going to invite all of you in the audience to submit questions for Professor Charo to me through the chat function. If you are a novice at the use of Zoom, the chat function can be found in the center bottom of your screen. It should be right between participants and share screen. You just need to click on that, find my name, Leslie Meltzer Henry, and send your questions in. We already have plenty of questions for you, Professor Charo. So without further ado, let me get started. A number of people are interested in having you say more about what counts as essential personnel and why should essential personnel be prioritized. Specifically, one audience member says, can you say more about why medical personnel should get priority over certain people from phase 2? For example, like food workers. Many high-risk health workers have better access to PPE, this individual writes, and care than other essential workers. Other essential workers also seem especially likely to contract the disease, and that also play essential functions and also take on a lot of risk, often for less pay.
Okay, that's a lot packed into one question, but I'm happy to try it out. First, I think I need to push back a little bit on one of the assumptions that was buried in there, which is that healthcare workers now have adequate personal protective equipment. Sadly, that is not in fact the case everywhere. So we still have large numbers who are still reusing masks that are supposed to be one-time use only. We still have people that are, excuse me, working in more crowded conditions than they should. We have people that are working in field hospitals that don't have the kind of easy protections that you can have in a full-scale hospital, such as being able to have certain kinds of monitoring equipment for sick patients kept outside the room so you don't need to keep donning and undonning protective equipment each time you walk in, but you can monitor from outside. So it's a little bit more complicated than people might think at the clinical level. That said, our committee did not disagree with the idea that some healthcare workers are not going to be as at risk as other people outside that sector. So we did talk about those who in fact are more at risk. So it's the ones with high patient contact, And that would include not just the doctors and the nurses, but also very specifically the orderlies and the janitors, maybe not the people who are the records clerks. So we were trying to make some distinctions there. In addition, two other factors. One has to do with making sure that people are confident enough to come to work. Because yes, the people who are preparing our food and delivering supplies and doing all the other things that are absolutely essential to keep society going, need to have the confidence to go to work. But with healthcare workers, it's not just the one job that they're doing, it's that they're actually going to make it possible for the rest of us to survive the illness. So it's like a multiplier factor in what they're doing, which gives a lot of people a first instinct, we need to protect them. The second is one which we really struggled on. And I've noticed that the ACIP did not put this principle in either, but if you look in the literature, there's a lot of discussion around reciprocity. The idea that some people have been asked, particularly at the beginning when there was very little protective equipment, some people have been asked to really step up and expose themselves to tremendously large risks at a time when many of us were able to self-protect. And that as a matter of reciprocity, perhaps they should be given first shot at, no pun intended, a shot. We dropped that because we recognized there were other people who were also being put at great risk. And so it became a principle that expanded beyond the ability to really capture it. But I do think that that is part of the instinct that is driving this. That said, we finally got comfortable with putting it first. On a very personal note, I will tell you that even with the protective equipment, I happen to have some near and dear relatives, nieces and nephews and such that are physicians and were working in hotspots, and the kind of thing they went through when they went home, which was kind of like the Ebola decontamination routines you might have seen from a few years ago, outside their homes or in the foyer, taking off everything, showering before they'd ever get close to their children, some not even getting close to their children for weeks at a time. It did make one think that perhaps we really ought to take care of these folks.
Mm-hmm. Thank you. Another question, somewhat of a bridge between the essential worker type question and questions about how we protect others. After being exposed to another positive case, this questioner writes, the vice president declined to quarantine, deeming himself an essential worker. So how should we think about what it means to be an essential worker and who counts and who must protect others?
Right. There's no easy or single answer to this question. So let's start with some of the efforts that have been made in the past. The Department of Homeland Security has its own list of people who are essential. And the Centers for Disease Control has a list, and these are slightly different lists because they're responding to different kinds of imagined emergencies. So if it's a military emergency, you might be focused to some extent on those people that need to be present in order to man or woman the various kinds of tools we use as countermeasures. Whereas if it's a public health emergency, you might be focusing on things like here, I said, healthcare workers. The second is that it's always going to be something that has a strong degree of local flavor, which is why it's left somewhat undefined at this national level. Here in Wisconsin, we're going into snow season, where the snow can easily be high enough that an ambulance could not get down the street unless we had snowplow operators out there. So it would not surprise me in Wisconsin if our public health authorities put that particular classification on the list. In Arizona, it's going to be air conditioning repair people during the summer when temperatures can be so high, people die from heat stroke. So it's hyper local. In general, though, we're looking at those people who are either producing goods we can't live without food, but we don't need the full variety of foods, but we need some minimum foods. We can live without toilet paper, so that's less essential, although certainly desirable, as we all discovered from the hoarding at the early stages. We were realizing how much the transport people were essential because can't get around without them, can't deliver things without them. More hidden behind the scenes are the people that are in production facilities. One of the limiting factors for vaccination turns out to be the production of glass vials. We may have enough vaccine, but not enough glass vials. So suddenly you realize, oh, there's a supply chain issue. So let's look at what is the supply chain step by step in order to be able to deliver vaccine, in order to deliver food, in order to make sure that the heating systems, gas, electricity delivery are all present. And that is how these things are developed. In addition, there are some people who simply can't work from home. It's not just the meat packers. And I have to say, you can argue that meat was not a necessary food, but in the intelligence community, you can't just zoom in from your kitchen to do highly classified work. You have to be able to go on site to special rooms, secured rooms for confidential information. So there are different kinds of settings. But I will end with this, which I loved. I was in California last year on a fellowship living in the Bay Area. And California was one of the first states to implement, in the Bay Area in particular, some really significant shutdowns. And we were all told, stay at home, don't go out if you don't have to. Businesses were all closing. And then exceptions were being made for certain businesses. And very early on, all of the marijuana dispensaries argued that they were essential services, not medical marijuana, which is already a dubious proposition in some ways because it hasn't gotten like FDA approval or something, but still, this was just recreational. Recreational marijuana said, it's a very stressful time. People need their pot. And California said, yep, you're an essential service. And they let those places open up for curbside delivery. So like I said, hyper-local in the decision-making about what counts as essential.
And more insights into that dichotomy between what we would like, what we want, and what we need. Let's move on to some questions now about the shortage that you were just describing. One of the questions is about the allocation that you recommend, along with the Academy, that 10% should be allocated globally. If we think about that, how much of the global population would that cover? And is there a threshold need in the United States that should be met before we start allocating 10%?
Yeah, I don't think there's a single answer to this, and I'm not sure that I can even defend any particular answer. But the 10% that we suggested, which was probably the least evidence-based recommendation that we had, was premised on the idea that other countries are going to do the same, and that the COVAX facility will be manufacturing. So it's not as if we were going to be covering the world with our 10%. And we also recognize that we might need to hold some back for special hotspots. I mean, if you've got an outbreak in a particular area suddenly that's very, very high density infection, you might want to go and vaccinate everybody there really quickly, even if they would be of 3 different phases. So we understood that holding back is something that you have to do for a variety of purposes. Is it the case that we should basically be saying, let's make it all and give it to the people who are neediest globally before we even ask about giving it to ourselves? And that might mean only a very small fraction of American citizens wind up toward the top of the list. I'd say that in an ideal world, that answer would be yes, because we would be a single globe with a single government. But in the real world, national borders do represent, in a sense, a kind of national level compact for protection of one another, so that we preference one another. We did not choose to fight the world order at the time that we were allocating vaccine, but it's painful. It's also why, though, collaborating in global efforts to produce vaccine specifically for global effort by supporting it financially and with personnel is really, I think, a moral imperative.
Mm-hmm. Given the shortages and the fact that the United States has pulled out of the WHO, do you think it's too late to work with Gavi and COVAX, or do you think that there's still promise ahead?
I don't think it's too late to work with them at all. We're talking about contributing, and I'd be very surprised if we weren't able to contribute at this point. Now, the WHO has been working itself on its own theory of equitable allocation among countries, trying to figure out how one balances country population with prevalence of infection, with frequency of death from infection, with degree of social disruption, and with degree of resilience. Some countries much more resilient than others. And so they're struggling with an even more complicated set of factors. Hard for me to believe that they would not welcome more participation to ease some of the very difficult choices they have to make in their own allocation scheme.
Mhm. And as we go from global to local, there are questions as well about how the United States should determine how many vaccine doses each state gets. Do you think the National Academies statement from your committee helps us with that? And if not, what would you recommend?
Well, there are actually standard practices for state allocation for vaccines that would help get you most of the way there in terms of state population and perception of need based on prevalence of a particular condition and also vulnerability. So, for example, in a northern climate, we're now entering a period of 3 months where life is going to be largely indoors, and that's going to put this set of states at higher risk of developing higher prevalence than, let's say, southwestern states. So even if the same number of people are infected today in, let's say, Arizona and Minnesota, you might want to actually pay more attention to Minnesota in terms of allocation because you can predict that there's going to be much higher rates of transmission. But again and again, I cannot emphasize this enough. The lack of information about how well the vaccine will work, if at all, at stopping transmission is a key uncertainty that is complicating everything. So in many ways, we're kind of acting as if we're pretty sure that if it lowers the level of symptoms, that it's stopping infection completely for some people and reducing viral load for others, which in turn we're predicting would reduce the probability of transmitting, even if it doesn't eliminate it. But there's a tremendous amount of estimation going into all of these things.
There is a lot of confusion, it seems, between a vaccine that might stop transmission and a vaccine that reduces symptoms. And so I'm wondering if you can talk a bit about that, because a question that has come up multiple times is how effective a vaccine needs to be approved. And of course, part of that is, what does effectiveness amount to?
Right. Well, the FDA announced that for the US at least, a vaccine could be approved if at least 50% effective at preventing you from getting infected, or if infected, preventing you from having a serious set of symptoms once you have been exposed. So that's not an overwhelming level of effectiveness. I'd say that's somewhat modest, but even the vaccines that we're used to, like the flu vaccine, don't have 100% effectiveness at all. And that is true even for some of these childhood vaccines that have some of the highest rates of effectiveness. So one thing that is really important is for people to continue, for self-protection and also to stop transmission, to continue using non-pharmaceutical interventions. Even if you've been vaccinated, even if you're having dinner with somebody else who's been vaccinated, you should still be careful about any kind of coughing, any kind of shouting in close contact, any kind of physical contact. You should still be washing your hands regularly. Until this infection has really subsided in frequency quite dramatically, we're going to have to continue to act as if there's a real risk out there. I'm hoping that with the vaccine becoming commonplace, maybe by 2022, that concerns about things like social distancing may ease up a lot, because we'll now no longer be assuming that everybody we see is a potential infectee. But even then, it may be that it'll be locality by locality as we monitor where there might be outbreaks and we reinstitute a more rigorous level of personal controls.
One individual wrote in as a law professor and a former pharmacist, wondering precisely in that area that you were just speaking about, whether you think a vaccine rollout will be a matter of the feds just taking more control and dictating a distribution policy along the lines perhaps of what you've outlined, or whether you think it's more likely that they'll punt and make it largely a state and locality decision as to distribution. And this individual writes, the CDC makes many recommendations, of course, but practice has shown that they often have little teeth.
So for a variety of reasons, and this is a law professor answering, so like just, recite Commerce Clause. For a variety of reasons, the CDC is extremely unlikely to try to exercise its muscle and mandate down to a granular level what will or will not be done. It will, however, issue guidelines. Now, the question is, how closely will states adhere to the guidelines, which themselves have been based on the ACIP recommendations, which were based on the National Academy recommendations, right? States are the primary source of authority in public health historically, and we've seen some of its drawbacks during this pandemic, I must say, in terms of the chaos that we have. But in the end, the advantage there is that states really know their own situations. So they will make the final call. That's why all 50 states have now been asked to come up with their own set of principles and their own set of allocation criteria. But the idea is that it should be informed by all of this material that's been sent out. And I can't speak to the state or the county where this particular person has worked, but I know that in some states, there is a fair amount of influence from the CDC guidelines to where the state bodies start from in their own decision-making about allocation. Another thing we haven't even talked about that comes into that locality issue is the logistics of it. The CDC guidelines may say you want to do, healthcare workers first, and then let's say people with high comorbidities, but the comorbidities may be widely distributed, but the congregate housing is actually easier to get to, or the congregate housing is in urban areas where you have better control over temperature and storage. Some of these vaccines require extremely low temperatures to be stable. Whereas in rural areas, you may want to wait for one that's stable at room temperature. You might want to wait for one that is single dose as opposed to double dose. So those things are also very much state by state discretion that has to be folded into these general guidelines.
As we think about distribution, it does seem like the National Academies committee made a defined decision not to use race as a criteria for allocation, even though there's fairly good data, both academic and empirical at this point, suggesting that certain racial populations are more likely to suffer significant harms from COVID-19. Why is it that the Academy's committee decided not to use race? Was it a conscious decision or not? And do you think it had anything to do with potential legal obstacles or concerns?
It was absolutely a conscious decision. And some of the many reasons that were, some of the many reasons that drove our decision had nothing to do with the law. It had to do with medicine, because we did not feel that the disease was having a worse effect in certain communities because somehow they were biologically distinct from the rest of the United States, because we don't think of race as primarily a biological category, even if there are some individual little traits here and there that have become associated with degrees of reproductive isolation in the past. Instead, we wanted to make sure we do not reify this notion of a biological notion of race, but focus on not race, but racism, and the way that racism has resulted in a distribution of income, wealth, housing style, work situation, access to preventive care that has disproportionately affected people who are the victims of racism historically and in present times. As a result, we thought that it was actually far more accurate to go at those underlying criteria and then use those as the factors. It also had the advantage of avoiding the use of race as a proxy where it becomes both under-inclusive and over-inclusive. Under-inclusive because there are individuals that fall outside these designated minority groups that also have some of these factors, and over-inclusive because there are some people, African-American or Latinx or whatever, who for a variety of reasons have actually not suffered some of these problems and so are not at higher risk themselves. Politically, I think it's obvious that trying to make it independent of race just takes away one aggravating debating point that was certain to get kind of rolled into politics. And the last thing we wanted to do was continue to politicize this thing. So we were very comfortable about this. And the way we wanted to make sure that at least the inequities that we had identified by racial or ethnic categories were addressed was to make sure that in addition to those individual factors, we also had that layering of the vulnerability index, so that when there wasn't enough for an entire group that represented these factors, we also geographically looked at where we're most likely getting people that have other things going on that make them even more vulnerable and in need of first attention. But as you yourself mentioned in our pre-call, I will say, Professor Henry, it does create a bit of a disconnect when the clinical trials are trying to recruit people by race to make sure they get a diverse population. And then we use the results of those trials to then map onto non-racially based categories for how to distribute. So we're not free of trying to do things in a race or ethnic based way yet. But we were hoping to do something a little bit more nuanced with that.
There is definitely some cognitive dissonance around when and where and under what conditions we use race in medicine. And so that raises a question I think a number of people on this Zoom would be curious to get your thoughts about. And that is, there is a long-standing historical misuse of research subjects, often based on race. And those populations are sometimes quite worried about participating in research. And as the data you showed in one of your slides suggest, also worried about taking a vaccine. Given that the Academies is not using racial categories and instead using what you might call a socioeconomic proxy for distribution, how can we address that reluctance that doesn't seem to be socioeconomic based, but is race based, arguably, in terms of reluctance to participating in research and taking new medical products not widely tested?
Well, it went beyond the charge of our committee to really delve deeply into how one develops public confidence and does outreach in a way that is evidence-based. Although we recognize that that was crucial because whatever allocation we recommend, if people don't take up the vaccine in proportional amounts, the framework essentially falls apart. That said, we do recognize that it's absolutely going to be key that we identify all the different reasons, different populations, including minorities that historically have been abused in research, identify all these different subpopulations and the range of reasons why their nervousness or hesitancy exists, and then find the right people to work with them, people whom they can trust. Right now, for example, Reed Tuckson, who was on our committee, is working very hard with all of the HBCUs, the historically Black colleges and universities, in order to develop pockets of expertise in outreach at those universities in their local areas, because that's one example of a group of people that might have some stature within communities that might be less willing to trust somebody who comes from Washington or from an entirely other part of the country and comes from a different racial or cultural background. It's why I thought the Santa example was really kind of intriguing, because that speaks to general anxieties. But there are people who are much more expert than I am at the use of church leaders, community centers, teachers, all the different kinds of people who can be part of an effort to communicate with communities that are skeptical and wary. That is a challenge, because with so many different communicators, making sure the message is accurate and consistent every time becomes that much harder. It's easier if you have one voice for the entire country, but that's also not going to be effective.
Given the time, I'm going to ask that any last questions that people have are sent in the next couple of minutes. I'm going to ask a few more questions, and we're going to aim to wrap up at 6:15 Eastern time. I know some of you are joining us from elsewhere in the country, but that gives us a little less than 10 minutes. So do send any last questions you have through the chat. In the meantime, can you say something about how you think the ACIP recommendations and the recommendations of the Academy are aligned and how they're different?
They're actually pretty closely aligned in terms of the early phases. Where they differ, I think, is more in the details. The academies are far more granular and make far more individual distinctions. I can't say much more than that because the ACIP has not finalized their work yet. But you see the same things, often with different words. And there are subtle differences, but they, for example, they put fairness, they rolled it into justice. Is there a difference between fairness and justice? Yes. Justice talks more comprehensively, perhaps, to a variety of factors as well as to outcomes, whereas fairness has much more of a procedural focus. But they are aiming at the end to the same thing when you combine fairness with equity and respect for persons. So I'm not sure that the differences are all that great. What we didn't see were some of the differences between our recommendations and some of the proposals that have been published in the New England Journal and JAMA and others. Proposals to use quality adjusted life years so that people who are predicted to live longer get vaccinated first before people who have a worse outcome predicted. That was first for therapeutics, but now we're seeing it for vaccines as well. Others who suggested lotteries, and others who suggested explicitly race-based categories. So that's where I think we're seeing the biggest differences is between some of those very specific proposals from academia and from some elements of the advocacy community.
As we close up, I have been informed that we actually have participants from as far away as Australia.
Wow.
And so we're really glad to have you. I'm sorry I left you out of my earlier comments. As we get ready to close, Professor Charo, is there anything else that we did not speak about that you'd like to say something about before we close?
I'm going to say one thing that's maybe not all that inspirational, but is very, very important. And that is that we have, well, maybe it is inspirational. We have really failed at positioning vaccines as well as all these non-pharmaceutical interventions as a matter of patriotism. I've been shocked at how often the protests against mask mandates were based on a kind of libertarian idea that it's up to me whether I want to protect myself, with very little understanding of how much it's about protecting your neighbor and how we're all in it together. And that's really at the core of public health, is the idea that we are all in it together and we do things that are not just for ourselves, but for others, even at some degree of sacrifice, whether it's quarantining people who've been exposed, but we don't know that they're ill, so that we make sure that they don't infect somebody else before we catch it, or that we wear masks when it's inconvenient. And I think for vaccines as well, we're missing an opportunity to really talk to people about how important it is to do this in the hope that it's going to help slow the transmission over time and not simply be a matter of protecting oneself. And to me, that social compact has not been emphasized nearly enough during the course of the pandemic. And I think it's going to be important in the rollout for any kind of vaccination framework to try to get that front and center for people and recognize why we're doing this for everybody together.
That sounds exactly right. Unity on this issue is going to be really critical going forward. And it's been interesting to see how other countries that have more specific, even duty to rescue laws seem to be further ahead in this space than we are, with very few duties to each other at all, except in those very specific professions. So it will be absolutely important to think about that going forward. And thank you so much for all of your thoughts. I think we are all wiser for having listened to the answers that you've given us to these great questions. Thank you to all of you for submitting so many terrific questions. And before we sign off, I'm going to turn it back to Diane Hoffman. Thank you again, Professor Charo.
Oh, listen, my pleasure, truly. Thank you for having me.
And my thanks to you, Professor Charo. That was a fabulous lecture. It was just a wonderful way to start off our speaker series. And thank you, Professor Henry, and to all of you who came to this. And I hope you will come to our next one on January 28th. So take care, everyone. Good night.
Thank you.